Langerhans Cell Histiocytosis, or LCH, is a fascinating disorder with a wide clinical spectrum. It was previously known as Histiocytosis X and is characterized by an abnormal proliferation of Langerhans cells, which are specialized antigen-presenting cells. What makes these cells unique is the presence of Birbeck granules, rod-shaped inclusion bodies visible under electron microscopy. LCH was once thought to be three separate diseases, but we now recognize it as a single condition with varying severity. Eosinophilic granuloma is a localized bone lesion, which may be unifocal or multifocal. Hand-Schüller-Christian disease is a systemic form with multifocal osseous lesions and occasional involvement of lymph nodes and viscera. Lederer disease is the most aggressive type, causing disseminated disease with multi-organ involvement and a poor prognosis. Temporal bone LCH occurs in about 19% of cases, often in young children, with a mean age of 3.2 years and a male-to-female ratio of 1.7 to 1. Symptoms often mimic chronic otitis media, including conductive or sensory neural hearing loss, chronic ear discharge, otorrhea and mastoid pain, and swelling. A key radiologic finding is the punched-out or lytic appearance of the temporal bone on imaging. This is a hallmark feature of LCH. Outcomes vary depending on disease extent. Unifocal disease responds well to local resection or radiotherapy, with a 95 to 100% cure rate. Multifocal disease requires a multimodal approach, including chemotherapy, radiotherapy, and steroids. Disseminated disease can be rapidly fatal, particularly in children under 2 years of age, with organ dysfunction. Surgical treatment of temporal bone LCH is now used more selectively, recognizing the high risk of complications, particularly involving the facial nerve. LCH is a rare but critical differential diagnosis in pediatric patients presenting with chronic ear disease, bone pain, or systemic symptoms. Early recognition and multidisciplinary management are key to improving patient